kick off today's press briefing.
Great. Thank you, Bridget, and thank you everyone for joining us today. Everyone seems to be complaining these days about how much they pay for their prescription drugs, especially when people have high deductibles and co-insurance, which is based on the list price of the drug. Last year, patients were charged $63 billion, that's with a B, in out-of-pocket costs. So today, we are taking action that should help millions of people who pay for their drugs and stop the insurers and PBMs from pocketing billions of dollars that they are taking that are meant for the patients who depend on prescription drugs to stay healthy. In the last couple of years, insurers and PBMs have been implementing policies which are called copay accumulator adjustment programs. They are taking the copay assistance provided by drug companies, which last year totaled $12 billion, again, that's with a B, that is meant for the patients, but not counting it towards the patient's deductible and out-of-pocket cost obligations. Frequently, they are doing it without the patients even knowing about it. People pick up their drug in the beginning of the year, but later in that year, when they learn that the copay assistance was not counting, when they pick up their drug, they're often faced with a bill of thousands of dollars. And we know these days people don't have that kind of money. And what happens, they don't pick up the drug that was prescribed by their provider. Patient groups, including ours, have been raising this issue publicly and with our federal regulators for the past several years. We have repeatedly urged the government to say that this practice is illegal and violates the cost-sharing provisions of the Affordable Care Act. After a couple of years of raising this issue, the Trump administration finally agreed with us and took action, and in 2019 issued a rule that said copay assistance must count for brand name drugs that do not have a generic equivalent. Unfortunately, after a couple of months, and I'm sure after intense pressure from the insurer and PBM lobbies, they said that they would not enforce it. And in the following year, they issued a rule allowing insurers to actually decide themselves if the copay assistance should count or not. Well, since then, you can guess what has happened. More and more insurers are implementing these harmful policies. According to analysis of 2021 marketplace plans by the AIDS Institute, 8 states have every plan in their state with a copay accumulator program. And in 30 states, more than half of their plans have them. According to the Kaiser Family Foundation survey of employer health plans, more than a quarter of the firms with 1,000 employees or more use copay accumulator programs. Since that rule was issued, despite the urging of patient groups, the Trump administration and now the Biden administration have failed to reverse this harmful policy and to make sure that copay assistance counts. We cannot wait any longer and be ignored any longer while people struggle to afford to pay for their prescription medications, and the insurers and PBMs take excess money from patients. Therefore, today, the HIV and Hepatitis Policy Institute, the Diabetes Leadership Council, and the Diabetes Patient Advocacy Coalition filed a complaint against the federal government, challenging the legality of the section of the 2021 Notice of Benefit and Payment Parameter Rule that allows insurers the ability to implement copay accumulator adjustment programs. I'll let our counsel, Paul Hughes of McDermott, Will, and Emery, discuss the exact legal claims. Before I do that, I want to say that it's not every day that the patient community files a legal complaint against the federal government and against an administration that we work closely with. But in order to stop this illegal practice by insurers and PBMs, on behalf of all the people who depend on prescription drugs and copay assistance to afford them, we have been left with no choice. I'll now turn it over to Paul to talk about the specific complaint. Thank you.
Thank you very much, Carl. I'm just going to provide a brief overview of the nature of the legal claims that are contained in the complaint. that you all should have a copy of by now. So as you're aware, we filed this complaint in DC federal court. That is a court that is very familiar with actions against the federal government and is very comfortable hearing cases of this nature. It's a court that certainly holds the government accountable when circumstances so warrant. In the complaint, we identify several different categories of claims, but simply understood, there are three general categories of claims that the complaint raises. The first is, Carl referenced, the Affordable Care Act has a clear definition of cost sharing. And we've demonstrated that the 2021 rule plainly conflicts with both the text and the purpose of the Affordable Care Act. And we believe that the federal court is very likely to recognize this conflict and identify that the statute, the Affordable Care Act, must govern, and as a result, this unlawful policy must be set aside. Second and related, there's been, as Carl described, a change in regulations. This sort of flip-flopping back and forth leads to heightened scrutiny by the courts. There needs to be particular consideration paid when the agencies so abruptly change course, especially when, as here, there are patient reliance interests at stake. Because we don't believe that the agency undertook the analysis that was required. We think that's an additional reason a court is likely to set aside this policy. Finally, we describe several different reasons why the actions at issue here are arbitrary and capricious. To start with, the regulatory definition of cost sharing that has ultimately been adopted seems to tell the regulated party that, that being generally the insurer or the PBM, it can decide for itself what cost sharing means. But that's generally not how the law works. The statutes provide the answer, the courts and the agencies provide the answer. The regulated party doesn't get to select for itself what law it wishes to apply. Moreover, in adopting this rule, the agency simply failed to consider alternative options. It didn't fully consider how this would harm patients. And we ultimately think it was simply arbitrary and capricious for the agency to base its rule on the presumption that insurers would act against their own self-interest in how they go about implementing this policy. So for all of those reasons, we are optimistic that a federal court will recognize that the policies at issue here are in fact unlawful, and under the Administrative Procedure Act, set them aside. Moving forward in this litigation, we anticipate forthcoming motions for summary judgment. We'll likely file a motion for summary judgment. The government itself may file a motion for summary judgment, at which point we'll understand how they will seek to defend this rule. But in all, we are excited to get before federal court. We hope to do so in short order in order to be able to get a decision that hopefully helps bring an end to these unlawful policies that, as Carl described, have had tremendous impact on patients. And with that, let me turn it over to George, who will more fully describe the nature of that impact and precisely why it is that we're bringing this litigation.
Thanks, Paul, and good morning, everyone. I'm a patient living with type 1 diabetes for nearly 40 years and currently privileged to be the CEO of both the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition, two affiliated advocacy organizations dedicated to affordable and equitable access to care on behalf of people living with diabetes. DLC and DPAC are very pleased to join with the HIV+Hepatitis Policy Institute in filing this suit against the Biden administration and the Department of Health and Human Services, though we are saddened that the suit is even necessary. I want to start by thanking Carl for his leadership on this important issue. He has been a champion for the HIV community in particular throughout his career. I'd also like to thank Paul Hughes and the team at McDermott, Will, and Emery for their dedicated legal work in analyzing the laws and policies in place and articulating our claim. We recognize that this is a wonky issue for many of you. Copay accumulator adjustment programs does not roll off the tongue necessarily. What's important to understand is that patients are getting taken advantage of here and harmed by these programs. Our organizations are joining together on behalf of patients who otherwise would have no voice. As Carl mentioned earlier, patients are struggling to afford their medications now more than ever. Rising inflation in general and rising drug costs in particular have created a perfect storm that has far too many Americans rationing their drugs or foregoing care altogether. We know in the case of insulin, 1 in 4 patients have reported rationing. We also know that over 60% of patients abandon their prescriptions at the pharmacy counter when the costs exceed $250. Copay accumulator adjustment programs are frankly an evil money grab by insurance plans and pharmacy benefit managers, and are a blatant, and we strongly believe, illegal cost shift back toward patients. Insurance plans are double and sometimes triple or more dipping the deductible and out-of-pocket maximums through these programs and putting the onus on the backs of vulnerable consumers. Imagine that you have been diagnosed with a chronic disease and prescribed a drug that will cost you hundreds or even thousands of dollars out of pocket before you've met your deductible. Your insurance plan offers no help to you during this period, so as a patient, you are on your own to pay the medicine that you need. Desperate patients can turn to their savings if they have any, a family member, perhaps a rich uncle, a GoFundMe page, but not surprisingly, millions turn to manufacturers for help through essential patient assistance programs. Now, let's be clear, it shouldn't matter how the patient financed it. They were responsible for solving the financial problem to get the medication they need. The patient did the work and should get the credit for the value of the medication they financed. The insurer is getting 2 or more times the value of the required deductible when these programs are in place. I spoke with a leukemia patient a couple of weeks ago who had one of these programs suddenly take the assistance value away from him. He has been on a particular drug for over 7 years and had been receiving manufacturer assistance the entire time. The first several years, he was appropriately given credit for the assistance, but when his insurance instituted a copay accumulator program, he had to spend thousands additionally out of pocket and is struggling. These are real people. It is also important to note that nearly 90% of these drugs have no generic or biosimilar alternative. The patient has nowhere else to go, and the lifeline that they have found is being yanked away from them by insurers and pharmacy benefit managers through these evil programs. As our partnership with the HIV+Hepatitis Policy Institute and the story I just shared implies, this issue is far beyond just diabetes. It impacts people with any chronic disease, cancer, arthritis, hemophilia, kidney disease, and more. These patients need expensive medications to manage their conditions and possibly to even survive. This isn't a financial shell game, it's their lives. We've been fighting these policies for several years, and not just at the federal level, but also in state houses across the country. 14 states and Puerto Rico have passed bills stating copay assistance must count toward the patient's deductible and out-of-pocket maximums. I am pleased to report that bills are currently on the governor's desks in both New York and Delaware as we speak. But it's hard to fight these in every state, and state legislation doesn't cover large employer-based ERISA plans, which cover about half of all Americans. There is a bipartisan bill in Congress today, H.R. 5801, with 57 sponsors. But as we know, it's difficult to pass federal legislation. That's why the phrase, "it requires an act of Congress," brings out pessimism for whatever task is ahead. But we shouldn't need a new act of Congress, since the Affordable Care Act is clear in our opinion on what should be counted toward the patient's cost share. We will continue to urge the Biden administration to conclude that copay assistance must count for patients. They will have an opportunity to do so when they propose the 2024 Notice of Benefit and Payment Parameters rule this fall. Hopefully, this complaint will provide them the legal reasoning to come to that conclusion. However, we need a permanent solution, and success with this complaint will provide that for the millions of vulnerable Americans relying on assistance programs to access the life-sustaining and life-saving medicines they need. They are why we're here today, and we look forward to a favorable outcome on their behalf. Thank you again to Carl and Paul for your work on this. We appreciate the partnership. And also thank you to the members of the media for attending this briefing today and helping us draw attention to this egregious practice. We'd all be happy to take questions if any arise.
Hello? Can you hear me?
Yes.
Hi, Joyce Frieden here, MedPage Today. I'm wondering, you just mentioned, George, about the notice of benefit and payment parameters. Can you talk about where that comes in? Has that provided relief in the past, or are you expecting that this time around?
I could cover that. Thanks, George and Joyce.
Sure.
So that actually comes out every year. And that's really what we are fighting, is a negative comment, a decision in there that says copay assistance, it's up to the insurers to decide whether copay assistance counts or not. And we did get a favorable, determination with the Trump administration, as I said in my opening comments, but they backed down. And then we've been trying in the last couple of years, even with the Biden administration, to get that reversed. And so we, as in the patient community, are still going to urge, as George said, to get the 2024 Notice of Benefit and Payment Parameters rule say that copay assistance counts, but that's only 1 year at a time. And until anyone can change that. So that's why we need a permanent solution, which we hope that this claim will provide. And Kathy, I could answer one of your questions. Do you see the impact of the lawsuit limited to the ACA insurance market, or might it spill over to the broader commercial market? I would appreciate Paul's comments too, but the Notice of Benefit and Payment Parameters rule does go into the commercial market, not the just the ACA marketplace. And I assume that this this complaint impact the broader commercial market as well. I think that's our intent. Paul, do you want to confirm that?
Yes, I agree, Carl. It's coextensive with the out-of-pocket provisions in the ACA, which have broadening effect into commercial markets, as you just explained.
And Kathy, your other question about the J&J lawsuit is a little different, and I'm not, I did read it, and but I've been focusing on these our litigation, and we did file an amicus, the HIV and hepatitis group, to that case, but they are different issues.
I'll say, Carl, I think they point in the same direction. That is a J&J suit against an actual payer entity that is claiming state law violations attended to the sorts of accumulators that are at issue. Of course, as has been described, we're challenging the federal regulatory structure that helps allow and enable these accumulators in the first instance. So certainly similar directionally, but challenging different particular aspects. And our litigation is very much at the broad programmatic side, focused on the underlying regulations and rules that help enable the conduct we've been discussing.
Thanks. And Gabrielle, in answer to your question, it was the rule before the 2019 rule that they said that the copay is I'm getting confused now because I'm looking at the chat and it's disappearing. So I will focus. So the one that they pulled was a favorable ruling, as I said in my opening comments. And that's the one that, yeah, we did get a favorable determination. And they pulled it in the, for reasons that we feel have nothing to do with the logic and the facts. And we bring that up in our complaint as well.
And I'd say that if you look at paragraphs 40 to 42 of the complaint, it provides that regulatory history that Carl described of how the agency started with the position change, then changed again. And I think we spell that out with clarity in that section of the complaint for any detail that you might like to see.
Paul, do you want to take Joyce's question? I don't know if you could see it.
Oh, I see that now. Thank you, Joyce. Now that we filed the lawsuit, typically we will confer with counsel for CMS. Typically lawsuits like this do proceed on competing motions for summary judgment, since these are legal issues that are presented. We will not typically engage in any discovery. We really want to tee up the legal questions for the court. In terms of who files the first motion for summary judgment, that's a discussion we will have moving forward. But I will say we certainly have an interest in expediting this case and getting before our judge as reasonably quickly as possible to ensure that we can get a prompt decision and get favorable results that would flow from that.
Hey
And Paul-
folks, sorry, just jumping in quickly. Carl, Paul, and George, if you don't mind reading the Q&A questions out loud, I think they're only visible to you, so just so everyone can follow along, that would be perfect. Thank you.
Thank you for the question I just asked, answered from Joyce was a question relating to the order of proceedings and who would file the next document or the next brief. And as I said, that'll be a determination that we make in the weeks ahead. But I will say we'll be looking to move this case promptly to a decision.
And Paul, do you want to do the next ones too?
Okay, Gabriel asked, this lawsuit alleges the 2021 rule conflicts not only with the ACA definition of cost sharing, but the definition provided by existing regulations. What are these other existing regulations specifically, though? Those other existing regulations, I would point to the complaint just because it's going to be the most precise discussion is around pages 58 to 60. And in particular, the regulatory definition of cost sharing that exists at 45 CFR section 155.2. Again, that's spelled out clearly in section 58 of the complaint that looks to the pre-existing regulatory structure that we think there is incompatibility with. Now, to be clear, we think the starting place is the Affordable Care Act, but then of course, the implementing regulations have purchase as well, and government action that's inconsistent with those regulations, especially not an explained inconsistency, is yet further reason why there is illegality here and why we are optimistic as to our chances before the court.
And there's
Carl-
a question by
Yeah.
Leslie about, does the notice of benefit and payment parameters rule apply to copay maximizer programs?
Yeah, Carl, do you want to take that or do you want me to handle
Why
it?
don't you take that one? First, I thought it was, does this case apply to copay maximizer programs? And that's why I gave it to you. But I see the question is, does the notice of benefit and payment parameters rule? So maybe I'm still going to give this one to you.
So I'll say copay maximizers are certainly in the same family of issues that we are addressing. And if we have a favorable result with respect to the aspect of the MBPP that we are challenging here, I think you would see direct and immediate spillover to copay maximizers. We do discuss maximizers in the complaint, so there is a discussion regarding that. That said, the aspect of the MBPP that we most immediately look at are the accumulator adjustment programs. And if that is remedied, I think you would see a relatively direct effect on maximizers, which in a way are sort of a variation on an accumulator program. So it is bound together, but we are principally focused, as the complaint lays out, on the straightforward variation of the copay accumulator. So the next question that I see from Leslie is, if we receive a favorable ruling from the court, will the 2024 benefit year be the earliest that policy change with regard to copay accumulators could be enacted? I'm happy to take a first cut unless George or Carl wishes to jump in. I think the favorable court judgment has multiple benefits. One, as Carl has described, these are rules that and determinations by the agency that are periodic, and a court that spells out the obligations of CMS will be important in a go-forward mechanism to help ensure that future benefit years, the MBPP in the future, is consistent with the ACA and doesn't contain the issues that we see here. That said, I would not agree that it's only potentially in a 2024 the benefit year, because what the regulation in a way does is create something of a safe harbor from a regulatory perspective for those payers which wish to adopt the copay accumulator adjustment programs. And if that is found to be unlawful, as we think it is, we would anticipate that many payers would recognize that something of a safe harbor provided by federal rule has been taken away, and therefore they need to revisit accumulator policies even before there might be affirmative action that would categorically bar them at the federal level. So to answer Leslie's question, yes, for 2024 benefit year, but not that would necessarily be the earliest. We would anticipate seeing some implications on an earlier basis. And I see George wanting to jump in.
If I can add to that, and what I think I did in my intro, I'm also in my other day job, the CFO of a professional services firm based out of Indiana, and have been the plan administrator of an employer-based ERISA plan for 25 years. A lot of that timing is going to depend upon the plan year that the employer's ERISA plan operates under. Many, if not most, are calendar years, so it's very easy to assume it's 2024, January 1, but if some have a September 1st, July 1st, depending upon when the ruling would come out, would also, I think, come into play as to when an employer might adopt or change their programs accordingly.
Well, I just wanted to add that our complaint asked, or that the notice of benefit and payment parameter provision allowing this is illegal, but we also say that we want the court to rule that copay assistance would count. So I hope they could, it would have to change things quickly. George, I see Joyce has another question. Do you want to take that one? Could you see that?
Yeah, who benefits? So the question here is, can you explain more about who benefits from copay accumulators? Obviously, the insurer benefits from getting more money paid to them, but does anyone else benefit? Well, I will say the insurer, or it could be a self-insured employer. So I have been pitched these plans by consultants many times as part of my other company, and they come to me saying, "You're going to save money. You're going to collect these copay assistance that the manufacturer is providing," and it's really I'm getting multiple. If I had such a program, which I do not. I would be getting the value of all of this assistance would effectively be going into the plan by virtue of the fact that the employees in their deductible substantially longer than they otherwise would have been. Now, the impact of that is that the plan is saving money, and they'll come back and say, well, we're going to keep overall plan costs down. And we see this in rebates as well. We're going to keep overall costs down, so everybody's premiums are lower. But what it really drives to is reverse insurance. We have the sick, the folks unfortunate enough to have a chronic disease, subsidizing the healthy by virtue of how these programs are working and how this money is being taken away from that patient and being taken by the plan. So it's really the insurer and the self-insured employer would be the two most likely to get the bulk of that copay assistance in these accumulator programs.
Paul, do you want to take Gabrielle's question about Medicare?
Well, I think the question that Gabriel asks is that in Medicare and copay coupons, what makes this rule inconsistent? And it's just, we're not looking at Medicare plans. Well, not necessarily entirely Medicare plans here. We're on the commercial market and ACA governed plans. So I think there's a bit of a different regulatory structure in play, and I don't think there is the assistance, manufacturer assistance is very well established and approved in these contexts. So I just don't think that there is a concern that Gabrielle might be suggesting.
And I could take Tara's question. Did drug manufacturer device sponsors in any way influence the filing of this lawsuit? I can say that they have not seen this. They've seen it just as you have seen it as well. And so we did not, I think some of them, probably knew about it. But this was all done by us, and we kept them, at an arm's distance, and they got it today, just like you all. Actually, Sasayo got it earlier. I alerted Sasayo yesterday, and I sent them the brief this morning as soon as it was filed. But this is all about the patient, and I think if anyone knows me and George, I've been fighting this issue for years, and on behalf of patients, it's just completely, it's illegal, but it's unfair. And I've been fighting this, with the insurers, the PBMs, the insurance commissioners, and the federal government for years. And I'm glad that we were able to do this. I've been trying to do this for years, and I really appreciate the partnership that we have with the Diabetes Leadership Council and DPAC as well, that we were able to split the cost on this. And so this is purely for the patients.
Yeah, I echo Carl's comments. This is all about the patients, and this has all been done in-house with Paul, Carl, and DLC and DPAC joining in.
Any other questions? Bridget, do you have any closing comments, or do you want me to?
No, definitely. Go ahead.
Okay, well, I just wanted to thank everyone and thank our partnership with Diabetes Leadership Council and Diabetes Patient Advocacy Coalition and our counsel, Paul Hughes. We look forward to working with you to win this case. And it would be great if the federal government didn't challenge it. That would save us money as well. And hopefully this will help in their, reasoning and logic as they approach the Notice of Benefit and Payment Parameters rule coming up. The copy of the complaint should have been in your press release that you received. If not, contact the PR firms. Also, it's on our website, and also a recording of this briefing will be available as well, and we'll put links on our website for that. Okay, so this concludes. Feel free to contact us if you have any questions. Again, thank you very much, and we look forward to continued discussions about this case as it unfolds.